But welcome everybody, and thank you for taking the time today to have a discussion about cancer-associated thrombosis in primary care. It's a great pleasure to be here tonight and to be with Dr. Tagalakis to have a discussion about the new data and provide some insights to cases we see all the time in clinical practice and for patients that are quite challenging sometimes. So I think it's important to have a look at the new data because things have changed dramatically over the past 12, 18, 3 years or so, and it's important to have a look at the data and make sure that we can digest the data together and extrapolate it into clinical practice, and we'll have cases to make sure that we do so. So this is a presentation that has received financial support from BMS Pfizer Alliance Canada in the form of an educational grant. There's potential conflicts of interest. The faculty members are eligible for honoraria from Thrombosis Canada. And as you're probably aware, BMS Pfizer Alliance benefits from sales and products that will be discussed in this program. But Thrombosis Canada is always there to mitigate potential bias. So the content of the program was developed by a planning committee that included Dr. Cynthia Wu, Dr. Tagalakis, Dr. Ebert, and myself. And recommendations involving clinical medicine are based on evidence that is accepted within the profession. And all scientific research referred to, reported, or used in this program in support of justification of patient care recommendation is confirmed to generally accepted standards and clinical practice guidelines. And this particular program is being accredited by 3 different councils. The first one from the College of Family Physicians of Canada and the Ontario chapter, Canadian Council of Continuous Education Pharmacy, and this is also accredited by the Royal College of Physician and Surgeon for accredited group learning section 1. So you may claim up to 1 hour of credit or 1 main pro plus credit or 1 CEU for this particular program. I talked a little bit about the scientific planning committee. We really tried to have an emphasis from coast to coast, having hematologists, having general internists, having primary care doctors, everybody that is really involved in taking care of patients with cancer that are often faced with a venous thromboembolic disease and its particular challenges in this particular condition. Obviously, before starting, it's always important to have a look at potential conflicts of interest of the speakers, and these are mine. My commercial interest honoraria and research grants are deposited at the Ottawa Hospital Research Institute, but they remain potentially important conflicts that you should be aware of. And my co-chair, Dr. Tagalakis, potential conflicts as well. So what we would like to do over the next 40, 15 minutes or so is to do 3 things. The first thing is to evaluate current evidence for the efficacy and safety of low-molecular heparin, but also direct anticoagulant, and how do they compare and how are they used to tailor management of cancer-associated thrombosis. We'll see that some may be associated with a high risk of recurrence or bleeding, so really it will be important for you and I and all of us tonight to really have a look at risk factors to consider when we make a decision to tailor anticoagulation, to initiate therapeutic dose of anticoagulation, and how do we appropriately select the right agent for the right patient at what dose. We'll obviously have a look at the data that's been published, but how does that translate into clinical practice guidelines over the management of cancer-associated thrombosis, but with really a flavor about Canadian practice. Although the practice will change from a province to another based on what is covered, we really will have an impact of what the Canadian key opinion leaders are thinking about the project, and we'll have a discussion about an algorithm that Thrombosis Canada has led that can help clinicians to really tailor anticoagulation in this patient, just giving some steps and guidance on what to think about when we make a decision for anticoagulation for cancer-associated thrombosis. As we're all really well aware, venous thromboembolic disease is not common in the general population. We're talking about 1 or 2 per 1,000 patients. But as soon as a patient has a diagnosis of cancer, the odds ratio is increased by 4-fold. And if that particular cancer patient is initiating chemotherapy, the odds ratio is 6.5-fold. So it's really common in patients with cancer. And this is really nicely illustrated in this nice observational study that was published in Blood in 2021, where investigators used Danish medical registries to identify 500,000 patients with first-time cancer diagnosis between 1997 to 2017. And then they matched them with 1.5 million individuals without cancer from the general population. The first thing that authors have reported was that the 6-month VTE risk for cancer patient is 12-fold higher compared to what it is for a general population. And if these cancer patients are initiating chemotherapy or targeted therapy, it's 23-fold higher compared to the general population, so a huge risk. They also looked at the 12-month incidence in the cancer cohort over time, and you can see from 1997 to 2017, it went from 1 to 3.4%, so a 3-fold increase risk of having cancer-associated thrombosis over the past 2 decades. And if you look specifically at those that are receiving chemotherapy or targeted therapy, the increase is about 6-fold. So even higher if your patient's undergoing anti-cancer treatment. That's important to keep in mind when we're thinking about this, because this is something that is very common. It's also something that is not going away. The incidence is just increasing over time. Patients are living longer, and based on the immunotherapy and targeted therapy, these may be associated with a higher risk. And then what's interesting is that increase is also parallel, not only with survival of cancer patients, but the fact that we use more and more CAT scans for staging. And therefore, we're more likely to find these clots in these patients that are associated with morbidity and mortality. And that's why it's something that we see quite frequently in the outpatient setting, but also in the inpatient setting when we're taking care of patients on medical wards, for example. Now, it's not only something that is very common in patients with cancer, it's really something that is associated with morbidity and mortality. When patients have cancer-associated thrombosis, they need to be on therapeutic anticoagulation. When we compare that to non-cancer patients, they have a much higher risk of having recurrent VTE or despite anticoagulation or major bleeding complication from anticoagulation, both of which are associated with a decline in the quality of life independent of the scale that you're using to quantify the QALYs. Some studies have shown that thromboembolism, so a combination of arterial and venous disease, is the second leading cause of death in cancer patients, putting forward the fact that it's not only morbidity, but it's mortality as well, which obviously will lead to an increase in resource utilization, all-cause healthcare costs, and something that we don't really think about too much, but it's also, VT is also a traumatic and distressing experience for patients and families, and often patients have very little support knowledge and don't really own VTE. It really increases their self-awareness that they're vulnerable and that their cancer is associated with some morbidity as well. And it can be an additional stressor. Not in every province are the different anticoagulants covered, and that may lead to costs and additional stressors for sure. So it's something that is common, frequent, increasing over time, associated with morbidity and mortality, and therefore probably worthwhile having a discussion on how to properly manage these clots in this special population so we don't have any associated complication. Now, as I mentioned in the introduction, this has changed so much over the past few years. If you look at the evolution of anticoagulant therapy, you could go all the way back to vitamin K antagonists, low-molecular heparin, 1980s. Then you have the low-molecular heparin dedicated trials in the early 2000s, CLOT and CATCH, and these really comparing low-molecular heparin to vitamin K antagonists. And over the past 3 years or so, we're seeing a lot of studies. Now we have 5 randomized controlled trials that are comparing different directal anticoagulant to low-molecular heparin. And as a clinician, we need to be able to understand this, of course, but also making sure that we can incorporate that into clinical practice. Now, Dr. Tagalakis, my co-chair, will provide us with some cases in the second half of the presentation, but we're really just going to ask you a couple of questions just to set up the stage. We'll show you a couple of cases so that you have something to reflect on as we're going through the data. And the first of a question, we'll ask you the question later and poll you officially, but what is the most common choice of anticoagulant for cancer-associated thrombosis? Is your first go-to a DOAC, or is it a combination of 5 days of low molecular weight heparin followed by a DOAC? Some of the DOACs need to be prescribed that way. Is it still vitamin K antagonist? Do you use low molecular weight heparin monotherapy as your first line? Or if you may be interested in the topic, but you don't necessarily initiate therapy on a regular basis and would refer that to the emergency room or to your local internist or thrombosis doctor or hematologist. So keep that in mind. And before we look at the data, we'll briefly go through 2 different cases. The first one is John. He's a 63-year-old gentleman diagnosed with lung cancer, stage 3 non-small cell lung carcinoma, currently on targeted therapy. His past medical history is only significant for hypertension and a 40-pack year smoking history. He's also known to have hypercholesterolemia. He has good renal function. He presented with a swollen right calf, and a venous Doppler showed proximal lower extremity deep vein thrombosis. What would be your first go-to drug for this patient? The second one is Kathy. She's 70 years of age. She is diagnosed with colon cancer, stage 2. She had colon resection 5 days ago. She's still in hospital, so in the post-operative setting. Her past medical history is significant for hypertension, type 2 diabetes. She also has normal renal function. The eGFR is 68. She has dyspnea, mild chest discomfort during hospitalization. You do a CTPA. She has a small segmental pulmonary embolism and left proximal deep vein thrombosis. So how would you treat that patient? Would your go-to medication be the same? Would it be different? And why would that be? So as we're going through the data, because we have a lot of data, we also have a lot of clinical practice guidelines. I want you to have a reflection of what would be your go-to drug, and then we'll poll you at when Dr. Tagalakis take over. I mentioned that we have numerous guidance and guidelines document that are helpful for you. These are things that we'll try to summarize within the next few slides. Some of them are relatively recent. Some of them are incorporating most of the data, but the data is coming in every day. And very recently, we'll focus on it a little bit later, but the Canadian Expert Consensus that was published in 2018 was published again in 2021 with an updated, trying to incorporate all the data that we have and trying to summarize the clinical expertise that we have, and we'll use it to go through the 2 different cases down the road. But generally, what are clinical practice guidelines currently saying? When if you look at the American Society of Hematology 2021 guidelines looking at prevention and treatment for cancer-associated thrombosis, and specifically for the acute treatment, for the initial portion of it, remember the first 5 to 7 days when the patient has a diagnosis, they would suggest a directal anticoagulant, and that would be apixaban or rivaroxaban and the PE and DVT dosing, remember, different atrial fibrillation, or a low molecular weight heparin for the initial treatment. Because remember, for the other DOACs, they need to have 5 days of parenteral anticoagulation before initiation for treatment of venous thromboembolic disease. So for the initial portion of it, depending if it's outpatient or inpatient, the American Society of Hematology guidelines are saying, well, a directal anticoagulant or low molecular weight heparin might be desirable. But what about the short course treatment, the initial 3 to 6 months? So when we look at the American Society of Hematology guidelines, they would recommend or suggest a DOAC over a low molecular weight heparin. And that's a little bit different than what we've been doing over the past few years. So it'll be important for us to have a reflection on the data and really have a look at why the recommendation are now suggesting a DOACs over low molecular weight heparin for short-term treatment of vitamin K antagonists when it's possible. Is there a certain patient population for which a low molecular weight heparin would still be the first approach? And if so, then who would that be, and how do we identify these patients? What type of baseline characteristics we need to look for? So let's have a look at the randomized controlled trial of different anticoagulants in the setting of cancer-associated thrombosis. I mentioned in 1980 it was low molecular weight heparin became available. In the early 2000s, we had the cancer-specific trials comparing low molecular weight heparin monotherapy to vitamin K antagonist. And when you look at these trials, there's about 8 different randomized control trials that looked at different low molecular weight heparin and compared it to vitamin K antagonists, mostly warfarin, and really followed patients for 3 to 6 months. So for all the trials we'll be discussing tonight, when we talk about or we think about efficacy, it's always about recurrent VTE despite anticoagulation, and that would be on the top. That's always efficacy. And then when we talk about safety, we're obviously talking about bleeding complications, right? And this can be major bleeding as per the ISTH definition. So that would be bleeding in a critical site, bleeding enough to drop your hemoglobin by 20 points or requiring 2 units of packed red blood cell, or a fatal event. And then those that are not necessarily meeting these criteria, but for which you still need to see a physician, go to the emergency room, having an important type of bleeding, these would be labeled with clinically relevant non-major bleeding. So major bleeding, clinically relevant non-major bleeding, when you combine them, they become clinically relevant non-major bleeding or clinically relevant bleeding. These are the types of things we'll look for safety of these different trials. So if we go back to low molecular weight heparin versus vitamin K antagonist, on the top we have a forest plot looking at these 8 randomized controlled trials. And what we see is that low molecular weight heparin is associated with significant lower risk of having recurrent VTE by about 50%. And when we look at safety, there is no difference in major bleeding, but it was a statistically significant lower risk of having clinically relevant non-major bleeding. So based on this, in the early 2000s, clinical practice guidelines were really recommending low molecular weight heparin as first-line treatment for cancer-associated thrombosis. But parenteral anticoagulation is expensive. It's parenteral, so it's daily needles. And since then, we had the directal anticoagulants that were licensed for DVT, PE treatment, licensed for atrial fibrillation, stroke prevention. But we didn't really have a whole lot of data in the setting of cancer-associated thrombosis until 2018. And after that, we had now 5 or 6 randomized controlled trials. The 3 biggest ones are shown here, comparing different directal anticoagulant to low molecular weight heparin. So the first one published is Okusai VTE cancer, non-inferiority, phase 3 randomized controlled trial, 1,046 patients receiving 5 days of low molecular weight heparin followed by edoxaban, 60 milligram once a day, but dose reduction based on renal function, weight, and drug-to-drug interaction. And the comparator was low molecular weight heparin at the dose of clot, the main trial that had shown a significant reduction compared to vitamin K antagonist. So remember that regimen, this is dalteparin, 200 units per kilogram per day for the first month, and dose reduction to 150 units per kilogram per day thereafter. Total duration for Okusai VTE cancer, at least 6 months and up to 12 months. So a little bit different than the other trials. The primary outcome for Okusai VTE cancer is slightly different. Composite outcome of recurrent VTE and major bleeding. And as I mentioned, they followed patients for 12 months. The second trial, much more modest sample size pilot trial, published 2 months after Okusai VTE cancer, compared rivaroxaban, the PE and DVT dosing, to dalteparin, as we previously described. The primary efficacy outcome measure was recurrent VTE, and they followed patients for 6 months. And the trial that was most recently published in 2020, the Caravaggio, their largest of the non-inferiority phase 3 trial, 1,100 patients comparing apixaban and PE DVT dosing to dalteparin. Primary outcome measure was recurrent VTE. Treatment duration was 6 months. Now, what happens when we put all these trials together? A number of systematic review and meta-analyses have been put on together, but we've chosen this one because it's really looking at efficacy and safety at the 6-month mark for the 3 main landmark trials comparing DOACs to low molecular weight heparin. And what you can see on the top, it looks like the different directal anticoagulants are associated with a slightly lower risk of recurrent VTE compared to low molecular weight heparin. It seems to be associated on the flip side, if you look at major bleeding, with a slightly increased risk of major bleeding complication, both of which are not statistically significant. So not as straightforward as when we looked at low molecular weight heparin versus vitamin K antagonist, where we had a lower risk of recurrent VTE, no difference in major bleeding, and decrease in the risk of having clinically relevant non-major bleeding. When we look at clinically relevant non-major bleeding for these trials, we can see that it seems to be associated with slightly increased risk as well. So it looks like directal anticoagulants, although cheaper and oral and associated with a lower risk of recurrent, may be associated with a slightly increased risk of major bleeding, clinically relevant non-major bleeding. But as you saw on the different slides, maybe there's differences between the different trials. Maybe there's differences between the different agents as well. And we'll try to tease that out for you and come up with some recommendation. So because it's not as straightforward as it is, I don't think we can say that everybody should be going on the DOAC. We really need to have looking at factors for clinicians to consider when we're selecting appropriate anticoagulant for patients with cancer-associated thrombosis. So what are people thinking about when they make that treatment decision? Well, obviously, you think about efficacy and safety. These are the first two things you think about. The second thing they're thinking about is tumor type, and we'll come back to that. And then they often think about the presence of CNS disease, because if you have brain mets or primary brain tumor, that is important to consider. And then drug-to-drug interactions will be important, because although DOACs have less drug-to-drug interactions than vitamin K antagonists, they may have more compared to low-molecular weight heparin. Are these clinically important or not? Obviously, reimbursement plan, it would be different from a province to another. And last but not least is patient's perspective, because that all will often sway us in a direction or another. So let's start with tumor type. Remember, I've shown you that maybe some of the DOACs were associated with increased risk of major bleeding complication. Well, if you look at Okusai VTE cancer comparing edoxaban to dalteparin, if you look at the composite of the primary outcome measures specifically for safety, major bleeding, and you compare the two arms, there was a statistically significantly increased risk of major bleeding for folks that received the DOACs, in that particular case, edoxaban. But when you look at the component, remember the definition, it wasn't really fatal event or intracranial hemorrhage. The bulk of the difference was really based on upper gastrointestinal type of bleeding in folks that received edoxaban compared to dalteparin. And a post-hoc analysis of that particular trial, stratifying patients according to the tumor type, non-gastrointestinal type of cancer to the right, gastrointestinal type of cancer to the left, you can see that folks receiving edoxaban that had gastrointestinal type of tumors were at higher risk of having major bleeding complication, mostly upper gastrointestinal type of complication with a hazard ratio of 4. And that's probably why some of the guidance or clinical guidelines, when you look at the fine prints, will say, well, we're going to suggest a direct anticoagulant, but probably be mindful if you have a patient with intraluminal tumor or a patient that has gastrointestinal type of tumor, because maybe they be at higher risk of having bleeding complication. It was a very similar story in SELECT-D, but remember the SELECT-D was much more modest for the sample size. It's not 1,000 patients, it's 406 patients, so the number of major bleeding is different, but the excess major bleeding with rivaroxaban was mostly due to gastrointestinal bleeding. Plus, the data monitoring and safety board for that particular study asked the investigators in 2016 to stop randomizing patients with GI cancer, upper GI cancer, stomach and GE junction, probably because they saw a difference in the risk of major bleeding in that particular population. So again, important to keep in mind. What's interesting about SELECT-D is although the differences in major bleeding was not statistically significant, it was statistically significant for recurrent VTE. On a safety aspect, it was significant for clinically relevant non-major bleeding. There was a discrepancy, an absolute difference of 6 to 9% between the two arms, 50% of which were upper extremity, upper respiratory tract and genitourinary type of bleeding. And that's also why often clinical practice guidelines or guidance document would say, be mindful if you have a patient with genitourinary type of tumor, because they may be at higher risk of urothelial type of bleeding. Now, what's completely different, I told you this when we had a look at major bleeding, the forest plot, is that in Caravaggio, when we looked at the bleeding outcome, major bleeding, there is no difference between the two arms. So no difference between apixaban or dalteparin. And they did a pre-specified but post-hoc analysis of a major gastrointestinal type of bleeding, independent if it's upper or lower, and there's no difference between apixaban and dalteparin at all. So is it because remember, these types of patients are heterogeneous, they have different tumor types, different stage. Is it because it's different patient population per se that were included in Caravaggio? Or is it because apixaban is given twice a day, so there's higher trough and lower peak, and that may lead to less bleeding? We're still looking into it. Observational studies will be helpful for that for sure. But the post-hoc analysis specifically looking at the bleeding event from Caravaggio is reassuring as well. And that's important to keep in mind when we make a treatment decision and which DOAC to use depending on the tumor type. Now, the other thing we often keep in mind is presence of CNS metastatic disease or primary brain tumors, because this may be associated, sure, with a high risk of recurrent VTE. We know, for example, gliomas are really pro-thrombogenic. They express tissue factor quite a bit, and therefore the underlying risk of VTE will be high. But it comes with, on the flip side, they're also at higher risk of bleeding complications. And that needs to be incorporated into your decision-making when you make a decision about a parenteral versus a neural anticoagulant. When we talk about primary metastatic brain lesions, we know that it's safe to start anticoagulation because a systematic review and meta-analysis was published in JTH a while back, looking at patients with metastatic brain disease that receive anticoagulation, admittedly for a different indication, a combination of low microwave hemorrhage and vitamin K antagonists. But when you compare the risk of intracranial hemorrhage for those that receive anticoagulation or not, there is no difference. And that's why ASCO, ASH, JTH, ISTH, they all say if you have brain metastatic disease, you can initiate anticoagulation if there's no signs of bleeding. Now, that odds ratio of 1.07 was for all patients, but when you look specifically at vascular tumor, renal cell, for example, melanoma, for example, the odds ratio will be higher. So these patients may be at higher risk of having intracranial hemorrhage complication, and important to keep in mind if we're initiating anticoagulation therapy. Now, does it help to, this data is mostly for low microwave heparin or or vitamin K antagonists. Do we have any data for directal anticoagulant? Now, we have 3 pieces of information. This is an observational study published in JTH in 2019, admittedly small groups, 67 with primary brain tumors, 105 with intracranial metastatic disease. And then they compare risk of having major bleeding complication and intracranial hemorrhage for those receiving a DOAC. It's a US trial, so mostly rivaroxaban versus low microwave heparin, again in the US, mostly enoxaparin. And you can see from a primary brain tumors, no patients with primary brain tumor receiving a DOAC had intracranial hemorrhage. When you look at intracranial metastatic disease, the risk of intracranial hemorrhage was very similar in those receiving low microwave heparin or a directal anticoagulant. The second piece of information is mostly for patients with intracranial metastatic disease. It was published in Blood Advances in 2020, and it really a nice collaboration between Israel and the Netherlands, and they showed similar findings, no real difference in folks receiving a DOACs compared to low microwave heparin. And the last piece of information was recently published in The Oncologist, only focusing on intracranial metastatic disease again, and then showed a very similar signal. So it looks like these are hypothesis generating. They're observational studies, they're retrospective, they have a lot of limitation, but they're somewhat reassuring that the DOACs can be used in that setting after careful review. At the end of the day, you need to use what you feel comfortable with. Sometimes with primary brain tumor, you may want to use a parenteral agent because it has a shorter half-life compared to DOAC. People may feel more comfortable reversing it in case of bleeding or any complication. That might be something to consider primary brain tumor to challenge patient to anticoagulation. But overall, it doesn't seem to be a whole lot of difference between the 2 groups, and more data is certainly coming. Drug-to-drug interaction is something we hear about quite a bit. We mentioned already that the different DOACs have less drug-to-drug interaction compared to warfarin, but more so than low microwave heparin. So we need to be mindful of that. The different DOACs are metabolized to the CYP3A4 for metabolic pathway and absorbed to the glycoprotein P. And the different DOACs will have different interactions with the different substrates. So you need to be mindful of that too, because you may have a drug-to-drug interaction that is important for rivaroxaban, but less important for edoxaban, for example. So that's important to keep in mind. And the reason why it's important to keep in mind is because if you have a strong inhibitor of both the CYP3A4 and the glycoprotein P, This may lead to increased plasma concentration of the DOAC, leading to higher risk of having bleeding complication. If you have strong inducers of both pathways, then it may lead to lower levels of your concentration, maybe putting your patients at a higher risk of recurrent event. Now, is this something that is clinically, this is all theoretical, is this clinically important or not? We don't know yet. More data is coming. I'll show you on the next slide, but this is data coming from Ontario that was published in JAMA Internal Medicine, and the investigators tried to compare the risk of hospitalizations for hemorrhagic complication among patients that were taking a DOAC and had a drug-to-drug interaction. So, for example, DOAC and clarithromycin is a no-no. There's a big drug-to-drug interaction, but there's not that drug interaction with azithromycin. And you can see on the right-hand side that folks that had DOACs with the drug-to-drug interaction had a small but statistically significantly increased risk of having a 30-day admission for major hemorrhage during the follow-up period. So it looks like, in some instance, it may be associated with significant clinical consequences for patients, so important to keep in mind. Now, that particular study was mostly AFib. Do we have anything specifically for cancer-associated thrombosis? Not so much, but it's coming. The TAC-DOAC registry from ISTH that was done by Dr. Sufei Wang, including 202 patients on a DOAC and targeted therapy, and they showed high risk of bleeding complication, especially in patients receiving BTK inhibitors. So that would be important to keep in mind for certain malignancies. And they also did a retrospective cohort study of 86 patients on low molecular heparin or DOAC, and those that were receiving VEGF TKI, and they saw a high bleeding risk in patients with low molecular heparin. They saw a higher risk of bleeding with folks on DOACs too, but it was too much of a modest sample size to really come up with a strong recommendation. But to keep in mind that it's sometimes anticoagulant in general may be associated with high risk of bleeding, and that needs to be mitigated in some way. And sometimes it's more agent specific, and we need to be mindful of that. Reassuringly, a post-hoc analysis of Caravaggio that was recently published showed that concomitant anti-cancer agent had no effect on the risk of recurrence or bleeding during Caravaggio. So that would be also reassuring that most of the chemotherapy anti-cancer treatment may not have any important clinical importance. Now, last but not least is patient's perspective, because I'm a thrombosis doctor. So when patients are seeing me, they have their cancer hat on, they don't have their clot hat on. And the first thing they're thinking, or the most important thing to them is, sure, use whatever type of anticoagulant, but do not use something that has interference with my cancer treatment. The second thing is efficacy and safety, of course, and lastly is the route of administration. And the reason why I'm saying this is often we'll have to go from parenteral to oral or vice versa, depending on what's going on during the cancer journey. And the patient will accept that. They just need to understand the rationale for why we're doing things. And more importantly, we need to reassess anticoagulation on a regular basis because things are changing over time. Patients may need surgery, biopsy, a new drug-to-drug interaction, or doing well. And so we need to adjust and tailor anticoagulation accordingly. So how are the recent guidelines applying all the data we just had a look at? If you look at what the key opinion leaders around Canada would say, they would say that that DOACs are preferred over low molecular heparin for most patients with cancer-associated thrombosis. Currently, the data is strongest with apixaban and edoxaban because they have the 2 phase 3 non-inferiority trials. Remember, Opus IVT cancer and Caravaggio. The risk of rivaroxaban is the use of rivaroxaban is also supported because they have SELECT-D, and recently Castadiva was recently published in CHEST as well, 146 patients, so a little bit more data with rivaroxaban. But if you decide to use a DOAC, you need to be mindful that you look at tumor type, probably to avoid them if you have luminal GI, GU type, if you have high risk of bleeding, if patients had GI toxicity or absorption concern, if there is some resection, drug-to-drug interaction, and discussion of it about patients' preference. And that's what we tried to incorporate into the 2021 algorithm, incorporating Caravaggio, incorporating the data that we just talked about, and highlighting the different steps that you need to go through in order to tailor anticoagulation for patients with cancer-associated thrombosis. And as I mentioned, Dr. Tagalakis will go through that. But the most important part is really the reassessment on a regular basis in order to make the proper decision. So let's go back to the case, and I'll share the screen with Dr. Tagalakis.
Thank you, Marc. While I wait to share the screen, so as Marc indicated, I'll be going through some of these cases that were introduced to you early on in Marc's presentation, and use these as a sounding board for you to address options for treatment for these patients using the algorithm that Marc just showed to you, and we can walk through that together. As Marc said, it was a work of a group of experts across the country that came together representing different individuals who manage patients with cancer-associated thrombosis. So we had oncologists, general internists, hematologists, thrombosis medicine specialists who were involved in coming in renewing the guide that we had published back in 2018, taking some of the latest data coming from the specifically from the trials looking at DOACs versus low molecular weight heparin for the treatment of cancer-associated thrombosis. So I'm just going to request now control, and I think we're good to go. So let's go back to John, who's 63 years of age. He was diagnosed with stage 3 non-small cell lung cancer 9 months ago, and he's currently on targeted therapy. His past medical history is only significant for hypertension, and as such, he takes perindopril, 8 milligrams, and it is noted that he's also on atorvastatin, 20 milligrams once a day. He is a long-time smoker, and we are told that he's got a normal GFR, noted there, of 75, and this obviously is important in determining usage of the anticoagulants, as they do have varying degrees of dependence on renal elimination, and that would impact the usage of these medications. So he presents to you with a swollen right calf, and a venous Doppler is done, which shows a proximal vein thrombosis. So, so here we are. These are the options for you to consider in managing, treating John's deep vein thrombosis. Options are A, to start a low molecular weight heparin and then move on to edoxaban, because as Marc noted earlier, edoxaban does require a 5-month lead-in of a parenteral anticoagulant. Option B is rivaroxaban, and for that there's no need for a low molecular weight heparin lead-in, followed by apixaban, and the option of using a low molecular weight heparin monotherapy is the final option D. So we're polling now, and I guess David will stop the poll in a couple of seconds. So we have 58% of participants who responded, and the most popular answer or frequently chosen answer was apixaban, followed by edoxaban, and then there seems to be an equal representation, but very small, 3% you said chose rivaroxaban and monotherapy with low molecular weight heparin. So if we go through the algorithm to see how folks came through this sort of treatment choice, Our aim when putting this together, this algorithm, was to address some of the considerations that Marc went through, specifically thinking about bleeding risk, thinking about presence of gastrointestinal or genitourinary cancer, thinking about drug-drug interactions between therapies that the patient is taking for their cancer and the anticoagulant that is to be used. And then also thinking about other type of risk factors that can increase one's bleeding risk outside, for example, a GI tumor type. So when approaching this patient, we considered that obviously it's a cancer-associated thrombosis, and we've put there that there should be no differentiation in the sense of changing our management, whether or not the patient has an incidental or a thrombotic disorder or a symptomatic thrombotic disorder. And that sometimes comes up, especially with, as Marc alluded to earlier in the presentation, with increasing rates of cancer-associated thrombosis over time, potentially being reflective in part with increased usage of cancer staging imaging in patients with cancer, that we may be picking up incidentally blood clots, whether they are PEs or even some DVTs. And we do have data to suggest that incidentally detected thrombotic disease in patients with cancer do have a adverse event rates vis-a-vis recurrence of thrombosis that are similar to patients that have symptomatic PE or DVT, that is cancer patients. So we wanted to ensure that we included these patients when thinking about how to manage a patient with cancer-associated thrombosis. So the first question one would ask is it safe to anticoagulate? So obviously, that is an important issue that we all have to address in our patients with thrombosis, because as Marc alluded to earlier, these patients may also have a higher risk of thrombosis and bleeding independent of being on an anticoagulant. So, for example, patients may have received chemotherapy and have a significant thrombocytopenia, for example. And so where there would be risks associated with anticoagulating this individual. Or patient may have a tumor that has invaded into, a pulmonary arteriole. So there may be vascular invasion where one would wonder whether or not it would be safe to anticoagulate. So these questions need to be thought about before addressing what type of anticoagulant or how you would manage this patient. So that was the first step. But having gone through that discussion, we then, and that sort of consideration, we then say that this patient is safe to anticoagulate. And then we proceed to the next question being, let's assess the bleeding risk. And, we discussed this around the table, actually, for quite some time, thinking about things that we would want to consider when thinking about somebody's risk factors for bleeding. And so given that there was significant sort of signals, especially in the edoxaban trial, the Hokusai cancer VTE study, as well as SELECT-D, where there was a signal for example, GI bleeding, we wanted to have this opportunity to think about whether or not this patient was at risk for any GI bleeding. So, for example, patients with known prior variceal bleeding or angiodysplasia or any other treatment-associated toxicity. So some of these medications that could potentially cause GI bleeding, such as nonsteroidal anti-inflammatory concomitant medications, for example, need to be considered at this point. We also want to think about high-risk intracranial lesions, as Marc alluded to earlier. Some of these tumors could increase one's risk of bleeding. So glioma, for example, or some of these metastatic diseases to the brain, like renal cell melanoma, thyroid cancer, that could potentially increase one's risk of bleeding. Hepatic impairment was also something that, or advanced hepatic disease is also something to consider at this point, and so on. So if you do find that these patients, have some of these risk factors, one or many of these risk factors, the group felt that in a high-risk type of situation, felt that low molecular weight heparin should be considered rather than a DOAC at this point in time. And truly, that comes from, when it comes to the GI aspect, comes from the signals that we noted in the Hawkeside Cancer VT and Select D trials. Number two, the long experience with low molecular weight heparin vis-a-vis management of patients with cancer-associated thrombosis, and the ability to sort of turn on and off low molecular weight heparin when needed due to the relatively shorter half-life of these medications when we are concerned about these patients having a higher risk of bleeding. Moreover, the reversibility, should there be a bleeding, that is quite critical, and we would want to manage this with reversal agents. Then potentially there is some ability to do so when using low molecular weight heparin, although there is some ongoing guidelines, some guidelines now that are suggesting the ability to deal with DOAC related bleeding that could potentially mitigate some of these earlier experiences that we had with DOACs and make it a lot more manageable. But we felt as a group that at this point in time, that if there was a high risk bleeding associated with this patient, that at least for initial management, it would be to suggest favoring low molecular weight heparin. However, if there are if it's deemed that the patient is at a low risk for for bleeding, then the next question that is discussed is whether or not we are dealing with an unresected intraluminal GI cancer or genitourinary cancer. And again, I won't, belabor the point here, and this is obviously based on the DOAC versus low molecular weight studies with the data suggesting a signal, at least with upper GI bleeding, specifically in patients with intraluminal GI cancer, less so with the genitourinary cancer group, but still a signal was seen in these cancer types. And so if these cancers, if your patient has this type of cancer, then the consensus around the table was to initially begin with low molecular weight heparin, or suggest favoring low molecular weight heparin in these patients. If there was no such cancer, and the patient, for example, like John, has a lung cancer, then we would consider moving on to the next question, which is to consider drug-drug interactions with DOACs. And that is something that, in theory, is important, although the data in practicality, the practical aspect of this, though, has yet to be substantiated by significant studies to determine whether or not these interactions are much more than what one would theorize would impact patients' risk of bleeding or patients' risk of recurrence. And so this is an important point at this point in time, to review patient medication history with a pharmacist, if you do have the pharmacist that you're working with, to determine whether or not there is a significant interaction with the DOAC that you are contemplating to use. And some of these drug-drug interactions, as mentioned by Marc, may not be just chemotherapeutic agents, but could also be, there's some data as shown by Marc vis-a-vis the TKI inhibitors. And moreover, there are non-cancer therapeutics that also may interact with some of these DOACs. A very sort of prevalent one that we always consider are, for example, anti-seizure medications. But if you've gone through this algorithm and there are no drug-drug interactions, then a DOAC can be considered. You can prescribe that DOAC. And I think one of the important things to consider at this next step is really, and I can't highlight it more, is to reassess your patient on a regular basis. So these are patients that, they're undergoing treatments, and these treatments can alter their hemostatic sort of potential for bleeding or not. It can alter their GI absorption depending on the types of therapies that are given. There could be changes in renal function. And so their status may change quite actually quickly. And so it is important to follow and monitor them as closely as possible. And often that would entail working together with their oncologist or hematologist. And I often sort of ask the patients when their appointments are with their hematology or oncologist and work around those appointments. They often have regular appointments, and so it's not so hard to follow these patients up. And so, and that's where at some point in time, we do have data to suggest that at a minimum, based on the original low molecular weight heparin studies that we had with, for example, the dalteparin and the CATCH studies, and now with the DOAC studies, that the treatment is for a minimum of 6 months, and that once the cancer is thought to be inactive, meaning the patient has completed curative therapy, or the patient is stable on maintenance therapy, there could be a consideration at that point to stop. So going on to the next slide. So these are some of the things to consider. What if John has no drug coverage? And so, that may entail that the patient, uses an alternative anticoagulant. I'll just go back for one thing. If there are CNS meds, we've discussed that. And I think the last question had to do with a history of upper GI bleeding that we've also discussed. So I'll go through the final case. And in this case, we have a 70-year-old who has a stage 2 colon cancer, recently had resection 5 days ago, still remains in hospital, known for hypertension and diabetes, and on these medications for these two conditions with a good GFR of 68 mils per minute, who develops dyspnea and mild chest discomfort in the hospital. As a result, gets imaging for workup of this, and this shows that she does have a PE and a proximal vein thrombosis. So clearly we have a similar case, but now we've changed the tumor type, and this is colon cancer, and there was just a recent surgery, so that may have impacted on this woman's risk of acquiring a thrombotic disease. So next slide is how would you treat Kathy? So these are the options: low molecular weight heparin followed by doxaban, rivaroxaban, apixaban, low molecular weight heparin, and then warfarin, and finally low molecular weight heparin alone. So for sake of time, I think I'll end the poll here, as we have about 56% of participants who've responded. And clearly here, the vast majority of participants would start low molecular weight heparin and would actually continue low molecular weight heparin, with 16% of individuals changing to edoxaban, presumably after 5 days. So I think the key driver here in the decision making, and I won't go through this as extensively as I went through the first case, it boils down to as we go through this algorithm, boils down to the fact that this woman has an intraluminal GI malignancy and had recent surgery. And so and moreover had a history of NSAID use, although that is a remote risk factor. Her GI bleed was enough 3 years ago, and presumably is not using NSAIDs anymore. But clearly the fact that there is a GI malignancy would favor, or at least suggest, according to this algorithm, to preferentiate initially low molecular weight heparin. And it doesn't mean, as 16% of the individuals there noted, they would switch to edoxaban. It is feasible to think about switching to anticoagulants down the road. Generally speaking, one can start with low molecular weight heparin and reassess your patient on a regular basis. And it may at some point in time be feasible to consider an alternative anticoagulant, such as a direct oral anticoagulant, if indeed the patient is doing well and, you know, her cancer status remains stable and there have been no bleeding noted, especially since we do have some data to suggest now with Caravaggio that potentially there may not be, at least in the apixaban or the Caravaggio study, a signal for GI bleeding. And so many of my patients are very happy to, when I explain my reasoning, to start with low molecular weight heparin. But a few months down the road, there may also be a discussion at that point whether or not it would be okay to switch it to a direct oral anticoagulant. And we wanted to sort of emphasize this in this algorithm that, you know, this is a fluid type of situation where patients can go back and forth. And so I think that is also a possibility. So once again, I think as things to consider, changing the tumor type to breast cancer, maybe at that point in time, we'd be actually more amenable to thinking about a DOAC. If she only had a distal DVT, I think data is pretty clear, even with patients who have cancer, whether they have a more distal clot versus a proximal clot. In cancer patients, the data would suggest that the risk of adverse events, specifically recurrence, is similar in those two groups, and so she should be treated accordingly. And if her eGFR is 40 mils per minute, it does impact, or it used to impact perhaps using the type of DOAC. So if you did choose edoxaban, then clearly at 40 mils per minute, one would use the lower dose of 30 milligrams because between 30 and 50 mils per minute, the lower dose of edoxaban is recommended. But the other DOACs or low molecular weight heparins would not change in their dosing. So I think the key takeaway messages we had for folks here was that DOACs, including apixaban, edoxaban, and rivaroxaban, provide an effective option to low molecular weight heparin for most or some patients with cancer and associated thrombosis, and are actually preferred for most patients. Use of DOACs in patients with GI cancers and history of GI bleeding is associated with higher rates of bleeding, but you know, that is something that is an ongoing, also, you know, with more recent data suggesting perhaps it may not be a DOAC, you know, all-encompassing DOAC effect. Potentially, it could also be a DOAC-specific effect. So that's something that is constantly being looked at. And patient characteristics, including bleeding risk, cancer origin, comorbidities, and potential drug-drug interactions, should be considered when choosing a specific DOAC. Thank you very much. And I'll check our, we had the opportunity. I just wanted to highlight two things. There is a program evaluation to fill in. This is very helpful to us so that we can modulate and develop our programs accordingly to what audience, to what you would like to hear about. And I think in the chat box, we do have a question no, it's in the question.
There's a couple of questions, Vicky. Maybe I can ask you, do you treat incidental events the same way as symptomatic events?
Yeah, in my cancer patients, I treat incidental events for the most part, the same as I would say the bottom line is yes. I'm not sure if you do the same or not. I mean, it's a different question in non-cancer patients, but where more of a risk-benefit analysis is taken. But in cancer patients, because we have some data to suggest that these patients, their rate of adverse event, meaning recurrence, is similar, I tend to treat them.
And then another question is, are you concerned about absorption of some of the DOACs? And Dr. Tulani was asking specifically about colectomy, right-sided colectomy, maybe, or small bowel resection. Is there one DOAC that is better for?
Yeah, so there is a differential absorption of the DOACs across the GI tract. And so there may be instances where, for example, apixaban may be impacted by having a distal ileal resection or colectomy. So it is important to look at where your DOACs are being absorbed.
And I think one last question maybe is, what do you do for secondary prevention? Vicky, you led the STEP-CAT trial with lowered prophylactic dosing. There's EpiCat ongoing. What do you currently do?
Yeah, so generally speaking, everyone gets treated for, I mean, this is for, a minimum of usual 6 months of therapy for the patients. And then I do have a reevaluation at that point in time. One option is to stop. Another option is to reduce the dose, actually. And then the other option is to continue indefinitely. In patients who, at the full dose. So in patients where there is active chemo being given, in patients where they have advancing disease, I tend to continue at a higher, at the therapeutic full dose. In patients where there is evidence now that there is disease remission or cure, in those individuals, I will tend to stop. And when I stop is a magic question also. Is it, 3 months after declaration of cure? Is it 4 months after that? It's a case by case, but generally I will stop. And then there are those patients that have remission, but remain on some sort of, whether they're on Revlimid, for example, for maintenance therapy, and I will continue on a lower dose in those individuals. We had experience, Marc noted, of the STEP-CAT study where we reduced the dose of, we did a pilot study where we reduced the dose of low molecular weight heparin at the time after 6 months to a prophylaxis dose. Granted, this was only 130 some patients, and most of these patients obviously had been treated already for 6 months and had survived those 6 months. And a lot of them were mostly breast cancer patients, but we actually saw no bleeding, and we picked up one incidental PE. And so it seems like potentially in patients who fare well for at least 6 months, there may be a possibility of reducing the dose, but we'll wait to see with EpiCat. So this is a large trial that's looking at reducing the dose of apixaban after 6 months versus a control, and to see how that works out.
There's so many questions that we won't be able to go through them all, Vicky. I apologize. Maybe one last, because it has to do with the algorithm specifically. We presented nicely the first block or the first step about bleeding risk. Dr. Zhang is wondering, do you need more than one in order to consider low molecular weight heparin in that setting, or do you need 2 or 3 to make that decision? What's your guess?
Yeah, obviously, I think 1 is enough, depending on what that 1 is. So, If it's, for example, a patient that had a angiodysplasia, but their last bleed, was more than a year ago, or some, I wouldn't feel uncomfortable saying, this is probably a remote bleed and we can move on and give this patient full dose anticoagulation. But if there is an accumulation, like he has angiodysplasia and has liver disease, and so that would then perhaps push me toward using low molecular weight heparin rather than a DOAC. So we only provide, we provide some of these scenarios or risk factors. And in the end, it's a case by case evaluation with you as the physician and the patient. And so there's no sort of correct answer. It could be one or it could be several.
Thank you very much, Dr. Tagalakis, for a great presentation. Thank you and have a great evening.